The content of this podcast is based on medical fact and evidence-based practice from credible, authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety.
Hey everyone, we're once again raiding the Fast Archives for another one of our favorite talks that we promise will become one of your favorites as well. This time, it's Brian Behn sharing his talk, The Folk Science of Sepsis. There are major misconceptions about sepsis and how to treat it in the EMS and critical care transport fields. And in reality, these misconceptions seem to even appear outside our industry. Of course, there are protocols and even a huge campaign to help improve sepsis survival rates, but have you ever stopped to consider why we're doing what we're doing? Well, Brian breaks down the science and controversies behind it all and gives us some seriously useful tips in this talk. Even though Brian's not going to be on stage this year, he'd be the first to invite you to join us in Wilmington for Fast 24. It's June 10th through the 12th, and we'd love to see you there. Now, as promised, let's get to the good stuff. Enjoy the episode.
So I want to start telling you why I'm going to talk about sepsis and septic shock today. So in 2017, my wife and I had our first and only child. And that year turned into a disaster. Shortly after birth, my wife was hospitalized with what they thought was Guillain-Barré syndrome. And then they did a whole bunch of treatment for that, which is basically you take plasma from like 50,000 people, scrape off the antibodies, put it in you. We did 4 or 6 treatments of that. It was a couple of months. And they go, well, that's not working. Let's take it out. So they put in a catheter and basically dialyze you and remove all your plasma and just throw it in the trash. And things were pretty rough. I was basically a single dad with a 1-year-old. And, I think the real low point was probably my 1-year-old's birthday. This is my 1-year-old daughter. She's now almost 5. But what you can't tell is that's her outside University Hospital in Denver. That's where we held her first birthday. And so it was a rocky year. But it got worse when, if you ask my wife, I gave her septic shock. Not something most husbands give their wives. And in my defense, I'm not sure I did, but maybe. My wife had sort of this autoimmune neuropathy and had these cyclical fevers. And one day she asked me to get the thermometer for her. And we have a 1-year-old. And at the time, we didn't have one of those infrared thermometers. And you can kind of see where this is going. My daughter was probably an asymptomatic carrier for hand, foot, and mouth disease. And according to my wife, I gave her the rectal thermometer. And shortly thereafter, she was hospitalized with sepsis and septic shock, actually, which really blew my mind because she said, I don't feel good. And I was like, oh, you're fine. And we got to the ER and her blood pressure was like 60/30. Her heart rate was 130. And what I realized was I don't know shit about sepsis or septic shock. And our education on it, at least in paramedic school, is very brief and arguably flawed. And that's what I'm hopefully going to convince you guys of today, that we're taught incorrectly about sepsis. And if you need another reason, annually 1.7 million Americans are hospitalized with sepsis. 270,000 die each year of sepsis, septic shock. And so I kind of did some digging around, and I asked myself first and realized I don't know what the hell I'm talking about, so I asked some other people. And I want you guys to try this when you get home. It's an interesting experiment, and maybe I'm wrong. Maybe you guys will be like, oh, dude, everyone knows this except you. It could be. But ask people to explain to you septic shock. Ask your coworkers, hey, explain septic shock to me like I'm a 10-year-old. And most people will kind of give you something about leaky capillaries and dilated blood vessels and an infection. And that's kind of the best answer I could give you a couple of years ago, too. And so, after seeing my wife go through this, and she was okay. She was discharged after, but she's fine now. I really took a deep dive into this. And it's not just dilated blood vessels and leaky capillaries. So, because if it were, we could just fix sepsis by, here's some antibiotics and here's a bunch of fluid, right? Like, your pipes are leaking and they're dilated. Let's fill them up. But it's not our fault. We are taught incorrectly, at least in EMS. EMS education should be based on the NHTSA Emergency Standards Manual. And if you look at this, I know that slide's hard to see. It's going to zoom in just a second. If you look at 2C under types of shock, right? If you guys remember, there's 4 types of shock. Sepsis is distributive shock. If you take nothing away from me today, that is wildly oversimplified. And sepsis is crazy, and it's a catastrophic failure of your whole body, basically. And I'm going to kind of walk you through it. And the reason we're going to do that is so you know how to treat it when you see it. So sepsis, generally, there's an infectious agent. You usually have an infection. You can have systemic inflammatory response syndrome without an infection, but we're going to stick to sepsis, septic shock. So it can be bacterial, it can be viral, it can be fungal. So you have an infection, and we just call that an infection. And then if you throw in organ damage, we call it sepsis. So an infection plus organ damage, sepsis. And one of the fascinating things I found when looking into this stuff, this is sort of a tangent, but I thought it was pretty cool. Why do the organs fail? Well, there's a bunch of reasons, right? People's organs fail because you're acidotic, you're maybe hypoxic. But there's another reason that was mind-blowing to me. And all of this is based on inflammation. You need a little bit of inflammation, right? That helps your body heal and get immune cells where they need to go. So a little bit is good. But in sepsis and septic shock, you've got a lot. You've got way too much. And it's runaway inflammation that's the problem. It's not the pathogens. It's your body's response to the pathogens that is actually the problem in sepsis. And it's driven by what's called a cytokine storm. And there's a bunch of cells that release a bunch of immune modulators that I'm not going to fit in 20 minutes, but it's a cytokine storm. It is runaway inflammation that is terminating these people's lives. It's putting them in the hospitals. It's not the infection. And so why these organs are failing has to do with mitochondria, and all your cells are mitochondria. And it's theorized that at one point, mitochondria are actually separate bacteria that kind of got together with another cell, and they're a symbiotic relationship. When mitochondria are faced with either hypoxia or an acidotic environment, they have 2 choices. And I don't remember the Krebs cycle, but they're involved in energy production. But the thing is, these mitochondria, they're just not that into you. If given a choice between saving you or themselves, they're going to save themselves. And so when they have this hypoxia, they have 2 choices. They can either basically commit suicide, or they can do something that's called estivation, which is basically they hibernate. And so people's organs are shutting down, and they go, well, we think sepsis is trashing their organs. But when we look at their organs, in pathology after, they're not trashed. They just stopped working. And it's because the mitochondria say, hey, I'm not dying for you. I'm just going to take a nap. But going back here, if we have sepsis and we add hypotension, we now have septic shock. So infection, organ damage, hypotension, you now have septic shock. And if you really want to explain it, it's basically just runaway inflammation that destroys or ceases your organs to function. It trashes your organs. And I want to talk about the current best practices here, because this is a little bit controversial, and it kind of blew my mind. What we do for sepsis is based on the Surviving Sepsis campaign. They're a group that kind of came together, I think, around 2012 and said, hey, let's put out some guidance. And what they said is, all right, here's what we want you guys to do. Everybody who's got sepsis, septic shock, or SIRS with elevated lactate, we want you to give them some fluids. How much? Anyone know the answer? How much fluids are you supposed to give to a septic patient? 30 milliliters a kilogram, right? Yeah, so we want you to give them 30 milliliters a kilogram. We'd like you to think about putting in some norepinephrine at some point. Maybe give them all the fluid. I think the guidance changed a little bit now that you can kind of do them both at the same time. But hey, we think you should use norepinephrine. And we want you to do this within 3 hours of them coming in your door. And the fascinating thing here, which we're going to go through, is why? Well, because we said so. And then Medicare got on board and said, hey, we like their work. We're going to make this bundle. It's called the SEP1 bundle. And if hospitals don't do it, we're going to kind of air this dirty laundry on the website and say, hey, you guys, they're not really meeting the performance metrics we're setting out. So a lot of people are stuck in this weird area where they don't really want to give someone 30 milliliters a kilogram. But if you don't do the whole bundle, you get dinged. I do want to tell you this just changed because I think a lot of people maybe didn't get this message. In 2021, they changed the wording. They said give them 30 milliliters a kilogram, or if you have another reason you can document, you don't have to give them that much fluid because that's a lot of fluid. But you say, all right, so we have these guidelines. Medicare's gotten on board. Hopefully this is based on evidence, right? Gets a little awkward here. This is from the Surviving Sepsis Guidelines. There's no data out there that says, really, what volume of fluid should we give these people? There's one study they cite. And I don't want to get too in the weeds here on how to read charts and things like that. But if you look at this, what they did is they said, all right, we're going to give a bunch of people with sepsis, septic shock, varying amounts of fluids, right? We'll say you got less than 7.5 milliliters a kilogram. And all the way over here, let's give some people 65.5 milliliters a kilogram, which is an insane amount of fluid. And this is all over 8 hours. And then we'll look at how they did over the next 30 days. And so if you're into graphs and stats, there's two problems with this. One is what we call error bars. These are the big vertical lines. And when these overlap, this is like the confidence interval. They go, well, we know the real results somewhere in there. When they overlap, it means they're not statistically significant at all. It means who knows? We don't know. The other thing that really makes it hard to take anything away from this is 30-day mortality. Are we assuming that the first 8 hours, these people got this fluid, but then for the next 29 days and 16 hours, they all had the same care? They all had the same comorbidities? Because these aren't adjusted odds. This is just the data. But they said, hey, we like this. But you know what we're going to do? We think the people did best between 15 milliliters a kilogram and 45 milliliters a kilogram. So how about we just split the difference? It's really what they did. And if you look at someone my size, I'm about 100 kilos. If you were to give me 15 to 45 milliliters a kilogram, somewhere between 1.5 bags of fluid and 4.5 bags of fluid. Yeah, the sweet spot's in there somewhere. Let's just split the middle. So this 30 milliliter a kilogram bolus, it's not really based on any evidence. And the whole 30-day mortality thing seems crazy to me because we don't know what happened in the other 29 days. The other thing is, in sepsis, in septic shock, 50% of patients are fluid responsive. 50% of them, you give some fluid, you will see an increase in their cardiac output. The other half, it does not help at all. And you go, well, a number needed to treat of 2 is pretty darn good. It's probably better than almost anything we do, right? Like 1 and 2, I can't think of any drugs we use that are that good. But the problem is 30 milliliters a kilogram isn't without harms. This is an interesting study from 2015. They go, hey, let's take some people who have sepsis or septic shock. Let's give them the 30 milliliters a kilogram. Let's see how they do. Well, 67% of them ended up fluid overloaded. 44% of them had to get diuretics. 10% had to get dialysis. And after seeing that, that's not a benign process. You have to get a large cannula stuck in your neck or a port put in. And 10% of these people had so much fluid in their chest wall, they had to put a needle in there and drain it. So while it helps 50% of people, it's also harming a fair number of people. And so what I want you guys to do is, this is my opinion too, just to be clear, not my employer's opinion. I want you guys to think about, is this patient fluid responsive? And in a hospital, there are some great ways to tell if a patient is fluid responsive. If you have ultrasound, there are great ways to do it. If they have a central line and you can do thermodilution, that's another great way to tell, are they going to get better with fluid? If they're intubated and you have end-tidal CO2 on them, which you should, and you do a passive leg raise and their CO2 goes up, you know they're fluid responsive. It just has to go up 5%. And you go, yeah, man, we should give this person some fluid. The problem for EMS is if they're not intubated and on a ventilator, we don't have a real great way to say, how do we know if they're fluid responsive? But what you can do is just give them some fluids. And if they get better, you can make the assumption they're fluid responsive. So I think it's totally reasonable to give them some fluids. And whatever you think that is based on your clinical judgment, 200 mLs, 500 mLs, reassess. Does their skin look better? Do they seem more lively? Is their cap refill improved? It's not an exact science, but it's arguably better than having 1 in 10 people having to get a needle in their chest because we gave them too much fluid. The other big thing in the Surviving Sepsis Campaign guidelines is vasopressors. Which vasopressor do you guys want to use in someone who's got septic shock? Norepi? Anyone? Anything else? What's that? Phenylephrine? Okay. Dopamine? No. All right. Yeah, dopamine's not popular anymore. Where I work, we kind of have epi and norepi as our bread and butter. But the Surviving Sepsis Campaign clearly says, hey, we want you to use norepi. And of course, we kind of go back to this meme again, like, okay, we understand you guys want us to use norepi. That's based on evidence, right? No, not really. The only evidence we do have is that dopamine is probably the worst choice out there. It does show a little bit of data that it has more mortality and more arrhythmogenic events. So you have a pretty strong case to not use dopamine. But I'm going to try to tell you, you can use epi, you can use norepi, and there is not a shred of evidence that one is better than the other. But there's a time, I think, for one versus the other. Another meta-analysis from last year, they found no difference either between Levophed and epinephrine. So there's no data, but that didn't stop the Surviving Sepsis Campaign from saying this is a strong recommendation, you should use norepinephrine. They actually said, hey, we think vasopressin's better, but it costs too much money, so use this. So the elephant in the room here that I see with sepsis is we keep treating sepsis like distributive shock. We say, this is a distributive shock. We know how to fix that. Let's give them fluids. That doesn't work. We'll give them a little bit of squeeze with a vasopressor, right? And that's how I operated for years. I'm not faulting anyone. That is literally how I operated, even when my wife is in the ER and I'm like, oh, you just need some fluids and maybe some pressors. Sepsis is incredibly complicated, and it's not just distributive shock. In fact, sepsis has basically all 4 types of shock in one. It's got elements of distributive shock. The runaway inflammation makes your body crank out the nitric oxide, which makes your blood vessels dilate wildly. So you do get some dilation. And you get a ton of nitric oxide coming out of the endothelium in your cells, in your vessel walls, and boom, your container's too big. You also have some hypovolemic concerns here in some of these patients. And this is where the history comes in your clinical judgment. These patients may be hypovolemic. They may not. Maybe they haven't eaten or drank in the past 3 days because they feel so poorly. Maybe they're breathing 40 times a minute and they're losing a tremendous amount of fluid that way. Maybe they've been vomiting for a couple of days. Maybe they've had diarrhea for a couple of days. Maybe they are in a relative hypovolemia because the container's too big. Or, maybe the fluid's in the wrong space because it's kind of leaked out of the capillary. So they may be hypovolemic. What's fascinating about sepsis is you also get a profound coagulopathy in sepsis. You get full of goobers in your capillaries. And what's important to remember is just because you see a better blood pressure doesn't mean you made things better. Blood pressure is a measure of a large artery and how much pressure is there. But if we don't have any blood perfusing through the capillary beds because it can't, because there's micro obstructions in all those capillaries, you really haven't done anything except make yourself feel better. So remember, blood pressure is not the same as perfusion always. It's sort of a good proxy. You need a blood pressure to have perfusion, but it doesn't mean you have perfusion. 35% of these patients have coagulopathies. That's 1 in 3 septic patients is throwing microclots. Their capillaries are full. And it comes in 2 flavors. It's not important that you really know this other than you understand you can have a bunch of little microclots in your capillaries. Another fascinating thing that happens in sepsis is your red blood cells actually change shape. Normally they're nice round discs that kind of bounce and squeeze and change shape to fit through capillary walls. In septic shock, they become sharp and pointy, they clump together and stack up, and they'll jam up capillaries. And lastly, and probably most importantly, this is the thing that I never received in my education, and maybe I'm an outlier. A large percentage of patients in septic shock have profound myocardial dysfunction. 44 to, I think, 61% of these folks, their heart is not pumping effectively. And it's for a number of reasons. But their cardiac output tanks. And so you can give them all the fluid you want, but if the pump isn't pumping, it's not going to help. It's just going to back up and make things worse, arguably. More than half have myocardial dysfunction. And when this happens, they're going to lose inotropy, their ejection fraction is going to tank, and their beta receptors actually become less sensitive to their own endogenous catecholamines, let alone the ones we're going to try to dump into them. So it's got all 4 types of shock in one. It's not just distributive shock. And so what do we do with these patients? Okay, we're going to give them some fluid based on their history, their presentation, our clinical judgment. And then we got to choose a vasopressor. And you're not wrong to follow the guidelines and just go with norepi. That's totally fine. But I think there's a better way to do this. So if we review our vasopressors, primarily Levophed or epinephrine, right? Levophed is mostly alpha 1. It's squeezing. Beta 1 is more cardiac contractility. So Levophed's got a little more alpha. Epinephrine's got a little more beta. They're pretty close, but epi's a little more cardiac. Here's what I'm starting to do, and I think makes sense. There's no evidence for this. I need to be clear. But there's no evidence for anything we're doing. So I think we can default down to a physiologic level because we don't have any evidence for anything we're doing in sepsis short of antibiotics. But I want you to feel your patient. If you go, hey, I think this person has septic shock, right? I want you to feel their extremities. Are they warm? Are they cold? And this will guide which vasopressor you may want to use. If their extremities are warm, you know they are not maximally vasoconstricted yet. There's still blood in those capillary, in the peripheral capillaries. They have room to vasoconstrict more and shunt that blood to the core and the organs. If their extremities are cold, you're left with kind of 2 options. One, they're maximally vasoconstricted already, and vasoconstricting them more is not going to get you anywhere. Or 2, they're truly hypovolemic and you need to do some fluid. So it's prudent to probably give them 500 mLs and then reassess their extremities or cap refill. Okay, so before I get off this stage, I'm just going to rehash all this real quick. First and foremost, make sure you identify which thermometer is the rectal one in your house clearly. You'll only make that mistake once, though. So the definition of sepsis is infection, runaway inflammation, and organ damage. If you add hypotension, you now have septic shock. Sepsis has all 4 types of shock. It's got hypovolemic, distributive, cardiogenic, obstructive. Pretty much everything we do is not based on evidence at all, which is crazy. Some of our treatments might actually hurt patients. I think 30 milliliters a kilogram is far too much for someone who's already on diuretics and has kidney failure. But you don't have to do it anymore if you work in a place that Medicare kind of dictates your care. You don't have to do that in the Step 1 bundle anymore. I think anything goes in vasopressors. I think you should tailor it to the needs of your patient. And I think you really want to think about, what are we trying to get? Are we trying to get more cardiac output? Are we trying to get more vasoconstriction? Or are we trying to get both? Thank you. Any questions?
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.